Hi, today we'll be talking about what to see in a post operative total knee arthroplasty radiograph. So, first thing to verify is whether the normal biomechanics of the knee has been restored or not. Have a look at the coronal and sagittal alignment of the prosthesis. Have a look at the posterior coronal offset, the patellofemoral offset, and the joint line level. So you need to have a long leg film, a scanogram of the operated limb, where you can calculate the placement of the prosthesis and see if this has been placed perpendicular to the respective mechanical axis or not. That is, femoral components should be placed perpendicular to the femoral mechanical axis, and tibial components should be placed perpendicular to the tibial mechanical axis. In other words, the center of the knee and the center of the ankle should form a straight line, or you can say that the mechanical axis of the limb should pass through center of the knee joint. However, we don't have the long leg films available with us all the time. So if we don't have that X-ray and we have to rely on a short film, you can use the anatomical axis of the femur and the tibia to calculate the placement or measure the placement of the prosthesis. On the tibial side, the anatomical axis runs parallel to the mechanical axis, which means that the tibial component should be perpendicular even to the anatomical axis. However, on the femoral side, there is a difference of around 5 degrees between mechanical and the anatomical axis. So, the femoral component should be placed in approximately 5 to 6 degrees of valgus to the anatomy, which means that the medial proximal tibial angle should be around 90 degrees and the medial distal femoral angle should be around 95 degrees. You should be able to appreciate the varus and the valgus alignment of the components. Here you see the femur is in valgus while the tibial component is in varus because it is sloping medially. This is actually the kinematic principle in action here. Here you see that the tibial component has been put in too much of varus alignment. Again, it's sloping medially. So such situations, the implant is going to fail because the acceptable limit is plus and minus 3 degrees. The sagittal alignment of prosthesis, the tibial component should always be placed in a posterior sloping way because that is what the normal anatomy is. If you happen to place tibia in an anterior sloping way, then it's going to decrease your range of motion. So it should be around, the slope should be around 3 to 5 degrees for a posterior stabilized knee and around 5 to 7 degrees for a cruciate retaining knee. The reason is very well known to you, the flexion gap. Regarding the sagittal placement of the femoral prosthesis, it should be placed in around 3 degrees of flexion. The reason is if you place it perpendicular to the mechanical axis in the sagittal plane, you will end up notching the anterior cortex. That is what happens in navigated total knee. If you do not introduce a little bit of, that is 3 degrees of flexion. And however, in manual total knees, where you put in the alignment rod in the medullary canal, it automatically introduces some flexion, and so the chances of notching are less. Also, kindly take in note of what the extended, hyperextended femoral component and a flexed femoral component looks like. Coming to posterior condylar offset, that is the protrusion of the posterior condyle of the femur beyond the posterior cortex of the femur, should be maintained even after surgery because that is what will decide the stability, mid-flexion and stability. You will see how if you reduce this posterior condylar offset of the surgery, you will introduce mid-flexion instability. Because we don't know about the exact value of this posterior condylar offset, it's better to use posterior condylar offset ratio, which should be around 0.8 to 1.2. Coming to patellofemoral offset, this again should be restored so as to avoid stuffing of the anterior compartment. Finally, the joint line restoration is important because that decides the tensioning of the collateral ligaments and also elevation of the joint line, which is commonly seen in revision total knee arthroplasties where the distal femur is deficient. That leads to apparent patella baja. All these leads to decreased functional outcome. So it's important to restore. The first thing is to find out the level of the joint. Uh, so you can use landmarks like fibular head or the tibial tuberosity or the erector tubercle. All these help and guide in restoring the joint line. Also have a look at the cementing quality, how well the cement has penetrated the bone, and the various joints have been properly cemented or not. It's always interesting to find out the type of implant that has been used. In fact, it's a good practice to know the brand, to identify the brand of implant or manufacturer of the implant that has been used, because certain complications are more common with certain implants. First thing is to differentiate between a posterior stabilized prosthesis and a cruciate retaining one. So the posterior stabilized one has got a post and cam mechanism. Post is there on the insert, which engages with the cam on the femoral side. The femoral component also has got a box to engage to accommodate this post. So here you see on the X-ray, in the sagittal view or the lateral view of the X-ray, you can easily appreciate that large box that was made. So indirectly, you can conclude that this is a posterior stabilized knee. While in a cruciate retaining knee, as you see here, there are no box. On the lateral view, you only see pegs which are for fixation. Because there was no post, so we don't need a box here. However, on oblique views, sometime you can see the cam of the femoral component. Though uncemented or cementless total knee arthroplasty is very uncommonly done, you should able to appreciate it if you find an X-ray. So you can see that there are pegs or screws for additional fixation because you don't have a cement mantle here. So the absence of cement mantle and presence of screws or pegs indicate that this is a uncemented prosthesis. When you see such an X-ray where there is absence of radio opacity on the tibial side, then it's very obvious that it's an all polyethylene tibial component, which is non-modular. There's no metal backing. It's really difficult to appreciate a fixed bearing and a mobile bearing insert on X-rays. However, you get some hints, like here you would see a metal projection and a metal marker on the interior part of the insert, which is to indicate the rotation and position of this mobile bearing insert. Do not get confused with a constrained knee, and this is not a consistent feature. Sometimes you get X-rays like this, which is for a mobile bearing insert, there are no metal markers. So the constrained knee and the hinged knee present as the most confusing X-ray picture to many of us. So you understand that the constrained knee is simply non-linked constraint like LCCK or TS knee of a striker, which means that the femur and tibia are not linked. There is only varus valgus constraint provision there. However, a linked constraint is something which is hinged, that could be fixed or rotating. Most commonly rotating hinge like MRH and RHK are used. Here we'll see on the left side the post of the insert is quite larger and broader because this is a constrained poly. Because of this increased height and thickness, this has to be supported with the help of a metal pin, as you can see here, and this metal pin is seen on X-rays. So do not get confused, and because this is not a hinged knee. Hinged knee, you need to have a horizontal pin that links tibial and the femoral prosthesis. Again, this is also a constrained knee. This one is also a constrained poly in a normal knee where metal stems are also there. Coming to the rotating hinge, a lot of mechanics is used. This is a striker rotating hinge. As you see, there is a metal bar that horizontally passes and connects, around which all the movements, hinging movement takes place. So this is the MRH. This is also an example of a hinged knee. You see heavier metal at the articulation. Again, this is a hinged knee, not a constrained knee. In more advanced forms, you can have endoprosthesis where distal part of the femur or proximal part of the tibia is replaced with metal along with the hinge. This is an example. This one is a patellofemoral joint. Now, coming to accessories, you can have sleeves, metaphyseal sleeves for better fixation that can be used with or without stems in femur and tibia. We can have tantalum cones also for managing bone defects, again in the metaphyseal area. And then you can have full wedges, screws, tibial stems. All these can be used with or without constraint. Hinged knee are used for global instability, while constrained inserts are used for varus valgus instability. Stems, on the other hand, are used for different purposes, like while you are trying to get additional fixation when the bone is soft, a person is obese, or there is a big defect. However, whenever we are using a constrained poly or a hinged knee, we always use an extended stem for femur and tibia because that decreases the shear stresses on the bone implant interface. Implant size that has been used and positioning is also important. You should be careful not to anteriorize or posteriorize too much tibial component or the femoral component. Should not be oversizing if you are placing an implant that is too much medialized or has got medial overhang, that it will irritate the medial collateral ligament and will always be painful. While if the tibial tray is posteriorized, you can have a sharp edge impinging on the patellar ligament. Special attention has to be given to the patella. See if patellar resurfacing has been done or not. If not, then if the patelloplasty has been properly done or not. For resurfacing cases, see if the resection line or direction is correct, parallel to the anterior surface or not. Asymmetric resections will lead to complications. Also, have a look at the depth of the resection. Less resection will lead to overstuffing of the anterior compartment and will be painful. Also, patellar tilt is important. More than 5 degrees of tilt leads to subluxation. Here you are seeing a dislocation. Patellar height is equally important. There are various indices to find out true patella baja and false. Obviously, here the patella alta is there because of patellar ligament tear. Finally, complication list is endless. It could present as anything. So just have a sharp eye for them. Notching of the femoral anterior cortex is common. Then spin out of a mobile bearing insert is also a peculiar problem associated with this only. Periprosthetic fracture of the femur, tibia, patella, very common. Now dislocation, frank dislocation is acute condition, generally post-traumatic. For patients who present long after their surgery, and so some radiolucencies peri-implant area, then consider aseptic lysis as a possible diagnosis. However, large areas of lysis in the peri-implant region and sometimes migration of the implant indicates septic loosening. Sometimes you will see a screw passing through the epicondyle, that is most likely for MCL avulsion. Heterotrophic ossification not that common, but is quite possible. And to look for subsidence of the implants, it's better to have a look at the serial X-rays and compare with the primary position of the implant. Sometimes the implant seems to have subsided, but it was initially or from the beginning it was placed like that. So it's always better to compare rather than directly commenting. And finally, you can have such weird X-rays as well. Hope you enjoyed it. Thank you.